Our next speaker is Dr. Stephen Mayberg, who is a clinical psychologist. He is the former director of the California Department of Mental Health. He retired from that position in December 2010 after serving for over 17 years. During his tenure, he embarked on an ambitious agenda that included major initiatives to reform the mental health system. These reforms reflected change based on programmatic research and program outcomes and accountability. Of greatest significance was his work on system change and integration. Dr. Mayberg has always advocated for better access, the reduction of stigma and discrimination, and for the development of programs that meet the unique needs of desperate populations. He got his undergraduate degree from Yale and his doctorate in clinical psychology from the University of Minnesota. Doctor?
Thanks, Maureen. People will ask, why would someone who's been out of the public sector for a couple years be invited to speak to something like this? And partly that has to do with Ellen Sachs giving me the opportunity to do something that you don't often do when you're in the mainstream of trying to run a large program. You're oftentimes reactive, hopefully occasionally proactive, but very seldom reflective. And this gave me the opportunity to, having stepped back, to look at what have we learned, what do we know about the mental health system that has led to too many of folks with serious mental illness ending up in our criminal justice system. So when Ellen called and asked me to do this, I wasn't sure whether it was like a Judge Lindley reward or sanction, because I did have to do an essay, but I actually think it's a reward, because I think there are things that we can do to change that trend. And I'm not going to speak as breathlessly as Hank Stedman. He's an East Coast guy. I'm more laconic kind of California guy, so I'll try and slow it down and do our Southern California speed. The issues come up, is this a new trend about more and more people in the system, or is it a long-term problem? Is this trans-institutionalization or not? I'm going to try and address that. I'm going to try and look at, as Marv said, you should tell people what you're going to say, give them evidence, summarize it, and then summarize it again, and then ask some questions. So I'm going to look at what I think are some of the contributory factors to this, look about how perceptions and public policy have probably pushed us in this direction, and then I really do think there are promising alternatives, and we started to hear some of those from Dave and Hank, and then we'll hear some in the afternoon and tomorrow about ways that we can start changing this trend towards criminalization. I think it's important to note that in my experience with the public mental health system, this has not been an issue that has been particularly high profile for the public mental health system. Where I have been most impacted by that has been by NAMI, or from going to meetings at NAMI. And a couple of years ago, someone asked at the statewide convention, how many of you have had contact with the criminal justice system? And almost the whole room raised their hand. So it's not something that's unique, but it's not something that we talked about. And talking to the people, many of the family members were shamed or embarrassed or thought they were unique in terms of that involvement. When I would go to sheriff's meetings, that was the common concern they'd have, saying, I don't want to be in the mental health business. I want to be in the law enforcement business. How can you help me? How can we make this move? So it's really pressures from other parts of the system that are making us look at whether or not this is a new problem or not. I think it's always been a problem. It's just becoming more of an issue for the public mental health system. For me, I started work right after Realignment 1 in 1993, and at that time, there were 3,300 individuals in the state hospitals that were civilly committed and about 550 forensically committed individuals. Last year, as you see, there were 600 civilly committed individuals and 6,000 civilly committed people. That's a pretty dramatic shift from treatment of people as an LPS commitment for those of you in California to forensic commitments. That's, 1,000% increase. Why did that happen? How did that happen? What are the reasons for that? Well, I think a lot of that had to do with financial incentives. We sometimes don't talk about that. We talk about it costs too much. But with realignment, counties were given the option of making choices about where to spend limited mental health money. They had a lot of flexibility, and oftentimes they would choose not to provide services for people who had involvement in the criminal justice system for a number of reasons that we'll get into. But the other part of that was that the state maintained the responsibility for paying for forensic care. So there really was an incentive to say, gee, let's put people where the money is. The money's with the state. Why don't we just send them to the state hospital or send them to prison, because then we can guarantee care and we won't take out of the limited amount of money that's available for community mental health. So state hospital beds is an example. The county pays for the LPS beds, the civil commitments. The state pays for all the rest of the beds. We've gone to 6,000 rest of the beds and 600 LPS beds. That's shown also when we talk about incompetent to stand trial. Someone talked about the MISS programs. The state will pay for felony incompetent to stand trial commitments and not misdemeanants. There's about one person who's a misdemeanant incompetent to stand trial in the state hospital, all of the rest. So it really has encouraged upcharging for individuals to get them into the state hospital because someone else will pay the bill. So we underestimate who's paying the bill sometimes determines what services you get. As I said, the county mental health don't have enough money to do all of the things. There's limited long-term care that's available with the declining state hospital beds, and actually there's limited 24-hour care, acute care. It's difficult oftentimes to get hospital beds. You've heard people talk about that whole issue of people waiting to get a bed or get a place. And when you look at that, our 24-hour care oftentimes is crisis care, and the average length of stay is less than 7 days. So people aren't getting the kind of extensive care they need, and depending on where you are, follow-up is really inconsistent. People get institutional care, 24-hour care, they're discharged, and in good programs there's follow-up and they're linked with community. Most often they're discharged to finding their own way, and as Rosina was talking about, the problem families have is saying they have no standing, and so people begin to recycle. And it's not just California. I think the trends certainly are community care versus institutional care nationwide. We've seen that switch. There's a decline in state hospital beds. Part of that has to do with the fact that state hospitals or institutes for mental disease, IMDs, don't get any third-party payment. And the feds aren't participating in that at all. And so it becomes a state or a local responsibility to pay for long-term care. And when you don't have enough money, you just triage that. And the other thing that people don't pay attention to is that there have been Supreme Court decisions that really have forced community care. So when we talk about the Olmstead decision, the message that's sent is, don't have people in institutions, have them in the community if you can go ahead and do that. So that's the trend that we see. The other trend we see in terms of finances is that Medi-Cal or Medicaid is not usually available for single adults, and that's usually with a forensic population. And so you see all of these folks that are out there who've graduated into adulthood with no way of paying for care. They're indigent care, and so that means they're probably not eligible for a number of programs. We talked about the fact that state hospitals, IMDs, jails, and prisons aren't also reimbursable for care. So there's no incentive to develop treatment programs within institutions because no one else is going to pay but the state or county. And in fact, if you go into a jail or a juvenile hall and you are Medi-Cal or Medicaid eligible, you lose it, and so you don't have access to that either. And so the reality is 100% of the cost for this care is either the county or the state. And so to some degree, by federal financial decisions, they really have forced a situation where people move into the criminal justice system because they're not willing to pay for care. The reality is, I mean, mental health is a business. You're going to develop programs where there's incentives to leverage the money. And also, people in the county level are smart enough to know that law enforcement, when it comes to limited county dollars, law enforcement is probably more apt to get funded than community treatment. And it's an issue, as Hank talked about, public safety, but it's also an issue of politically more acceptable. I don't know any county where someone's running for elective office where they solicit and say the mental health director supports me, but they sure say the sheriff supports me. And I think that probably reflects things that it's probably a disadvantage to have an endorsement from the local mental health director, whereas having the sheriff endorse you really is positive politically. You laugh about that, but decisions are made based on those kind of perceptions. And I think the local mental health programs, especially as you move further into the system, have significant concerns about the impact of adverse events, that media coverage is pretty horrendous when someone who's in the mental health system does something adverse or something that's headline raising. And there's a lot of tendency for blame. I mean, it's why didn't the mental health system do this? What did you do wrong? Why did you let them out? You don't have the same response from the media when a parolee does something. It's people go, oh yeah, well that happens. And when you have that kind of intense media scrutiny, the local pressures are much more and the accountability is much more. And Marv is going to get a call from the Board of Supervisors saying, why did you do this? Why didn't you do that? Much less apt to happen that Sheriff Baca's not going to get the call when someone goes out of Twin Towers and does something than Marv's going to get a call. So it's just, that is sort of the reality of the world we live in. But as an example of not wanting to accept that, we have a great program in California called Conrad, Conditional Release of Parole for Mentally Ill Inmates. It's got a great array of services. The recidivism rate is less than 10%. Counties have the right of first refusal, and most counties won't take the program. Part of the stigma that's attached to and the accountability that's attached to it. But the problem with that is that we have a disconnect between state-run programs and local programs, and that's where people fall between the cracks. We see the same issues occurring with parole outpatient. That's less of a case now with AB 109, but where people were discharged from prison with mental health problems. County mental health didn't want to pick them up because they didn't have the treatment plan. Parole didn't have the resources. No one provided services. We see it sometimes in terms of probation, screening, and evaluations and recommendations. They may recommend treatment, they may recommend placement, but it's county mental health money, there's no coordination there. So we always end up in a discussion, who's going to pay for the service, who's going to provide the services, and with a limited amount of money, people tend to be somewhat possessive. Another issue we don't talk about, than we should, is this whole issue of involuntary versus voluntary treatment. We've alluded to it. It is the elephant in the room. In California, our LPS Commitment Act is variably implemented. Depends where you live in the state, whether or not you're going to be 5150'd or involuntarily detained. And it really is a fungible definition. I mean, it really depends on resources. If you have more resources, you tend to be more apt to get services. If there's less resources, there's not. We heard Hank talk about CIT. The reality is, most of the time, police or law enforcement end up being the first responders. If you have first responders who are in the mental health system, you're going to get different outcomes than otherwise. And based on that lack of clarity of not knowing if someone's even going to be 5150, oftentimes the choice is jail over hospital. One of the complaints I heard from the sheriffs all the time was law enforcement would still be doing the paperwork and the person they brought into the hospital was already out on the street. They would rather be doing something preventing crime rather than doing paperwork for something that was a revolving door. So, and the other issue in terms that really is surprising to me is this whole issue of assisted outpatient treatment. Laura's law here in California, only one county is implemented even though it's eligible. Question, why is there this kind of concerns about voluntary versus involuntary care? So the question is, who really is responsible for this? Who is accountable? And there is a lack of clarity. And because of that, people fall between the cracks. The default position is lock them up, put them someplace else. And the other part that we don't pay attention to, the Welfare and Institution Code is very different than the Penal Code. And so how in the mental health system we interpret things is different than how courts and law enforcement interpret things because they're looking at it from a penal code point of view. From a running the state hospital point of view and trying to do institutional stuff, I don't think that our courts have helped us. There's the U.S. Supreme Court decision Cell that talks about involuntary medication, saying people don't have to take that to be restored to competency. And so there is no incentive. I mean, so someone sent to a state hospital to be restored to competency to stand trial, and they say, no, I don't want to do that. I rather, and as long as they're not violent, they continue to languish. In the prisons, this Jameson v. Farabee, people can refuse medication even in prison. And what happens is people don't like the administrative burdens of trying to have hearings, administrative hearings, legal hearings to do medication. So they take the course of least resistance is to do nothing, not medicate, people decompensate, and that's what happens. In our IST system, there are incentives for state hospital treatment versus jail. That from a financial point of view, oftentimes it's a way of reducing jail crowding. You just send someone off to the state hospital. We heard the question about malingering at one of the state hospitals, Patton State Hospital. 25% of the people who were referred incompetent to stand trial were found to be malingering. There's an incentive from the defense attorney side and from the inmate side, from the prisoner side. State hospital is a lot nicer place. They do have bocce ball courts there, Dave, than being in jail or in prison. I mean, you get to go to movies, you get to do arts and crafts, and you get credit for time served. And what ends up criminalizing people is people say, do you want to plead? You've already served your time. They go, okay, yes, the court is dismissed, but they have a record. The other problem that we have is that in jails you can't medicate people. So people do decompensate, and even times when they have been restored to competency, they return back to a jail, refuse their medication, and they start this vicious cycle of decompensating, having to go back to the hospital. The reality is the systems are disconnected. That's part of what contributes to the problems we have. The impact is we have inadequate or insufficient treatment resources for 24-hour institutions. People in jails and in prison oftentimes opt not to get treatment for whatever reason. We heard the story that Marv was talking about, doc, send me back to the regular place. This isn't any fun here. And so we almost guarantee recidivism. I mean, when you look at the mentally ill parolees, we were looking at that. Their recidivism rate was above 80% when they were discharged from state prison in California. Obviously, it's not just a mental health issue. People have addressed this. Substance abuse is a huge issue that in our current system, 70% of the people who are seriously mentally ill also have a co-occurring. In our forensic system, over 90% of the people have both a substance use issue and a mental health issue. Drug use and possession is a crime. People are going to get arrested for that. And the behaviors of substance users oftentimes brings them into contact with law enforcement. They're impulsive, they're lower frustration tolerance, their aggression, or they're pursuing dollars to buy their drugs. And so untreated substance abuse exacerbates the problem we have. We did an interesting study. We were talking about who's in the system when I was at the state at the Vacaville psychiatric thing, and we looked at consecutive admissions over a year period of what were the people like in the prison system referred for mental health treatment. It surprised me. The average IQ was low average, probably in the 80s. The education was 8th grade. People had dropped out of school. They came from lower socioeconomic status, but what was most surprising to me, that 2/3 of the people had brain injuries. We heard that reference about trauma, traumatic stress disorder that Marv was talking about, and it was from fights, falls, drug use, but a whole new set of circumstances. They hadn't been employed, their family history. For many of these, they were single and their family had really given up on them. Long history of violence. And the consequence is that there really are a complex set of factors that contribute to people staying in the criminal justice system who have mental health issues. It's not just their mental health diagnosis. And so what that means for treatment is our usual cognitive or outpatient treatments don't really work. A structured environment might be required in the community. We need to coordinate substance abuse, mental health treatment, and educational and vocational programs are really important too. What that means is we don't have those kind of programs in the community, so we set up a revolving door for that reason. Homelessness is certainly contributory to part of being in the criminal justice system. We know about substance use, mental illness. It's hard to live on the streets. Most of the crimes are crimes of opportunity. Marv talked about opening the monster drink and the pack of nuts. I mean, people aren't doing terrible things. They're highly visible. You see the homeless every day. They're more apt to be arrested, and there's a lack of coordinated response to homeless. The other factor that we haven't talked much about that contributes to this is stigma. Oftentimes people don't want to get treatment because of the stigma attached to that. The community oftentimes sees violence and mental illness connected, even though we know that's not the fact. The media certainly plays it up. And then there's always the blame people. I just inflamed me with the NRA was after Newtown was talking about gun control and saying it's really not guns, it's the monsters, the mentally ill monsters who are causing the problem. That doesn't help any of us. There's a perception out there that the community is safer with individuals locked up rather than in outpatient or community treatment, and that's pretty pervasive. And so it's hard to establish community programs. And it's even harder because people don't want them in their neighborhood, that NIMBY issue, not only for community programs, but for 24-hour care programs. And so having to cite a place in the community is really hard. So you send them to jail or prison. There's no place else. And once again, the elected officials are more apt to fund public safety programs over community treatment programs. So if you had a debate in front of a board of supervisors or the legislature about saying, we have $1 million, do you want to lock up more people or do you want to provide community outpatient treatment? Most of the time people would say, I'm worried about safety, not about treatment. And we talked about the tolerance and expectations. People are more tolerant of parolees acting out, the differential response from the media, and funding for control agencies, law enforcement is probably more than for treatment programs. And we're actually seeing some of that in some counties with the prison realignment, AB 109. There are some counties where 100% of that money has gone to the sheriff and jails, none to treatment, none to probation, none to supervision, none to diversion. That is scary. So, summary, the issues of responsibility, there's conflicts between state responsibility and local responsibility. The feds have bowed out of this. Conflicts between what's law enforcement responsibility, mental health responsibility, conflicts about, is this a mental health issue, is this a substance use issue, or both. And so what ends up happening is it's no one's responsibility and people end up locked up. Finances, insufficient funds for mental health and substance abuse generally. There's no federal dollars available for treatment of most forensic populations. Our laws and regulations are really constructed to have the incentive for the state to pay rather than local, and partly that's a fear that local won't lock them up enough. But the paradox is counties have the responsibility for care, and that's where all the good treatment is, and that's where all the good programs are. And if you're disconnected, people aren't going to be able to access the programs that work. And then the stigma issue we talked about, perceptions, individuals don't seek treatment, the public thinks mentally ill people are violent, the lockup's safer, and don't want unpredictability. There's not enough structured care, there's not enough specially trained professionals, there's a lack of specific programs for this population, and there's not third-party participation. So I'm going to have to go and those things. I have to go fast. There are policies that work, there's programs that work, and there's potential opportunities. Our homeless program that Steinberg started showed that you can change the curve in terms of costs. Law enforcement training is really important. You heard the CIT, the Memphis program stuff, the SMART and PET teams. Barry Peru is going to talk about that. Mobile crisis makes a big difference. Court and criminal justice involvement. We talked about behavioral courts, mental health courts, drug courts. There's a MIOCA programs are back, mentally ill offenders, crime reduction programs. Great results, great data. We know that mental health needs to be available 24/7. There needs to be a point of contact and responsibility. We need to do co-occurring programs, and as someone asked, we need to have violence prevention programs, bullying programs, domestic violence, because we know the impact of trauma and how that ends up in our criminal justice system. We need to start having mental health systems in the jails and prisons that are connected with community programs. We need to do better screening, case management, and dedicated staff. We need to reduce stigma by all kinds of ways. NAMI's doing a good job of that, and the Client Network's doing a job of that. I mean, the choice is, it's more stigmatizing to be a felon with a mental illness than just to ask for treatment. Prop 63 gives us a lot of opportunities. Los Angeles County has done some great stuff. If you look at the emphasis, as you heard earlier, on cultural competence, this whole issue of urgent care, being able to get people access before a crisis, 24/7 responsibility in the full-service partnerships, the homeless programs all work. The community partnerships that were talked about are really critical. Early intervention and prevention programs are important. Stigma reduction programs are important. And jail programs are important. Now I'm becoming like Hank and talking faster and faster. Co-occurring programs are really critical. We can't solve this without working together. We need, Prototypes here in LA does a great job of looking at a criminal justice involved population, having specific programs, great results. Conrad works. Healthcare reform gives us some opportunity to get third-party payment for these folks. Prison realignment gives us some opportunities. And research shows that there is a good return on the investment. It's cost-saving. It's a good investment. And people do better in the community with an array of treatment options rather than locked up, refusing medication, and decompensating. Thank you. See, Hank, I can talk fast too when I need to.
Hi, Dr. Mayberg. I could talk to you all day.
Well, I'll be around all day.
I know. I'm from Orange County, And I spoke to you last year at the One Mind for Research, and we talked about Prop 63 and the MHSA funds and what we can use that money for. And I was part of the MHSA steering committee for a while there in Orange County, representing NAMI. And what I noticed is that they consistently did not want to use that money towards any type of involuntary care. And if the majority of the patients are ending up in the criminal justice system, 50%, we house nearly 14 to 2,000 per day in our Orange County jails. So it's telling you we are not targeting the high-risk, non-engaged patient over and over through the Moore's recovery system that they like to use on that scale. And so we've noticed that if we can take that money, and it all goes to the behavioral health care department, 100% of that, and we got $95 million in Orange County of MHSA funds for this year. That's up $20 million from the year prior to that. We got $20 million more, and we were told we had so much MHSA funds in Orange County. They had $50 million in reserve. When I was there one day, we put another 11.3 we banked of unused funds we couldn't spend on enough voluntary programs in Orange County, and they banked it. So if we got 20 million more this year, I don't know what they're using that funds for, but we found out nobody does want the responsibility for these people, their liability for them. And so we know community courts can be the answer. We know that assisted outpatient treatment is probably where these funds need to go for our loved ones who are falling through the being left behind.
I think it's a debate that goes on and on about voluntary versus involuntary, and I think that as we've found, like in our full-service partnerships and in some of our outreach programs, that you can engage and pull people into treatment if you pay attention to what their needs are. And certainly when we talk about the mental health courts, and Dave talked a little bit about are they voluntary or not, probably not. I think the major issue really is, should this money be spent on hospitalization? If we can avoid hospitalization, if we can avoid any institutionalization with good treatment and good follow-up, that's probably the way we want to go. But the big issue for me is really the stigma reduction part of this, is how do we get people to accept community treatment, allow the community to provide the treatment, and to have access available to everybody.
Hi, I know that you kind of had to gloss over the stigma reduction program, and I was wondering if you could spend a Southern California moment talking about the stigma reduction and whether or not the stigma reduction not only involves patient perceptions, but also the public's perceptions.
It's a good question about, is there a difference in terms of stigma reduction from a patient perspective and from a public perception? And the answer is really there is. And so, but the nexus between that is if the community thinks poorly of people who are in the mental health system or mental health treatment, that contributes also. So I think that the good stigma reduction programs are a combination of media campaigns, public service announcements, and the one-on-one presentations by family members and consumers who have been part of the system, showing that they're just like everybody else and that treatment really does work. And so part of that is making it personal, and personal does make a difference, but it's hard at one person at a time to change some of these really deep-seated prejudices, discriminations, and stereotypes about mental illness.
Hello.
A lot of old, familiar faces here.
Yes, good to see you. I totally agree that so much of what we do is governed by fiscal incentives. And as you talk about fiscal incentives and talk about the research that shows that things like diversion are cost effective, and then you think about, well, why don't we do more of that? And the sense that I have is it's the siloed way that we have our funding flow through different bureaucratic, through law enforcement, mental health, whatever. And so my question is, in your experience at all those state budget meetings you've gone to, your experience at the national level with working with other states, Has any state been successful in looking at the pot of money across bureaucracies, across mental health and law enforcement, look to see what actually is cost effective, and then not be governed by which organization, which bureaucracy has to spend the money, but in fact try to demonstrate that an overall cost savings would work?
It's a great question, and I think there's some local examples, but there's certainly not any national and state examples where people have braided funding and looked at what's really best for the community and best for the individual. And when we do put that kind of investment in place, you see really good results. I think that we saw that with AB 34/2034, where mental health use their money for whatever it takes, and interestingly enough, the savings from that 50% were not in the mental health system. They were in the jail system, the hospital system, the social service system. So we have to begin looking at a much more holistic fiscal approach rather than a categorical approach to doing this, and that's where I think the research becomes really, really important. We've started to do that a little bit with homelessness. We certainly haven't done that with people in the forensic criminal justice system.
Hi, Doctor. I have a question about AB 2034, Laura's Law. I happen to be a client of Mental Health Services and also work for the county now. And I also have discussions about the pros and cons of Laura's Law, AB 2034, with NAMI friends and people I work with. And one of the things that I always get confused about is during the implementation phase, who would be the people who would actually administer meds to those clients who are resistant to receive medication? That's where the question always comes up. Who would be the people to administer the meds?
Well, and it is a hard question. Who makes the decisions? What are the levers that people have? And I think we really have to look at two parts of the system. We talk about treatment-resistant clients, and I think Hank talked about client-resistant services, and that it's really a partnership where people have to work together with their providers to be able to provide the appropriate treatment. And there are times when there are going to be disputes or differences, and there's got to be a mechanism to work that out that works for both the recipient and the provider.
I'm hoping that we could get your PowerPoint emailed to us and some of the other PowerPoints. I didn't catch a lot of things that I wanted to. And my question is, when can people be involuntarily medicated in jail? Because I know that in my county it's happening more and more. So there must be some certain circumstances.
There are certain circumstances when people can be involuntarily medicated. One is if they have a mental health unit in their jail. Los Angeles County has that. There is some legislation that allows certain counties to be able to do that. But in most instances, medication and forced medication in jail is not something that we see. And what amazed me, this is just it's not really answering your question, but I was looking at that, and what happened oftentimes when people went from the state hospital to the jail, and I was following up why they didn't take their medication, is jail formularies were different than the hospital formularies, or that they changed the medication, and that person said, well, I take an orange pill, and you're giving me a purple pill. I'm not going to take that. I don't know you. I don't trust you. And so the reasons were, from my point of view, resolvable, but from the person who's in a difficult situation, explaining it, working it through are complicated. So I think figuring out how to do the whole issue of medication and treatment in jails and in prisons becomes really critical for us.
We are due for lunch, and we want us to be on time. Shall we take one more?
And then you can grab me after lunch or any time. And some people grab me and shake me, and some people hug me. I don't care. Either one works.
Dr. Mayberg, William J. from Benefits kind of a project. I met you in conferences.
I'm sorry, I can't hear.
I'm William J. from Backup, main conferences, like up north, for example. I have a question about State Hospital. There's one near Fresno called Coalinga State Hospital. It's the newest one. They got, I think, 5. They got Metropolitan, Napa, Atascadero, Coalinga, and Patton. And there was an article in the LA Times about the new hospital halfway between San Francisco and Los Angeles. And the people of Coalinga in that community said that a lot of the people in that hospital are sex offenders, and they're there because of committing a sexual offense. And there's a lot of NIMBYism, not in my backyard, sentiment in Coalinga about the hospital. And it was constructive toward the end of your directorship of the State Department of Mental Health, which is now part of the State Hospital Department. Yep. Can you comment about Coalinga State Hospital and the NIMBYism?
I can comment about that. Coalinga State Hospital is where the sexual violent predators are, and that's another example of legislation really confusing and stigmatizing mental illness, because most of the sexual violent predators are not seriously mentally ill. In fact, I don't think any of them are. But it is moving them into a, quote, treatment system. It took 5 years to place that facility. No one wanted sexual violent predators in their neighborhood, and so when you go there, it's got guard towers and barbed wire and all those things. But the reality is the treatment programs there are very different than the treatment programs at all the other state hospitals. The treatment programs there really are relapse prevention programs, as opposed to programs that treat seriously mentally ill individuals at the other state hospitals that have the whole array of hospital-based services. So you're right that I think lumping sexual violent predators in with the mentally ill is a problem. I made a promise to NAMI that we wouldn't have sexual violent predators in the state hospital. That was part of why we wanted to separate that. So it's just one hospital, but it is a problem.